Now we've come to the much awaited segment of our academic sessions, the COVID vaccines and immunity, a panel discussion. And as chairpersons, we have Dr. D.K.D. Matthew and Dr. Sankar Andenikumara and Dr. Preethi Wijegoonewardene as our moderator today. Over to you all, sir.
Today the panel discussion, the members of the panel discussion is Professor Suranjith Seneviratne, Dr. Krishna Murthy and Dr. Eru Fernando. And Professor Suranjith Seneviratne, DPhil, Oxford, MBBS, MD, DPath, MRCP Path, MRCP, FRCP, FRC Path, FCCP, Professor and Consultant in Clinical Immunology and Allergy, Institute of Immunity and Transplantation and Health Services Laboratories, London, UK. Professor Suranjith Seneviratne is currently at the Institute of Immunity and Transplantation, Royal Free Hospital and University College London, and Health Services Laboratories, London, UK. He completed his basic medical degree at the Faculty of Medicine, University of Colombo, with first-class honours, 8 distinctions and 10 gold medals, and was placed first in his year. He completed his MD in Internal Medicine and trained in Clinical Immunology and Allergy at the John Radcliffe Hospital in Oxford. He completed a Doctor of Philosophy in Molecular Medicine at the Weatherall Institute of Molecular Medicine, University of Oxford, as a Commonwealth Scholar. So far, he has authored 256 journal publications and has published in journals such as Nature, Science, Nature Medicine, Blood, American Journal of Medical Genetics, American Journal of Human Genetics, Journal of Experimental Medicine, and Journal of Allergy and Clinical Immunology. Professor Suranjith is an international expert in immunodeficiency, autoimmune, allergic mast cell disorders, and immunogenetics. He is the director of the Center for Mast Cell Disorders and the president of the UK Sri Lanka Immunology Foundation, an organization that contributes to immunology and allergy education in Sri Lanka. Our next panel member is Dr. Krishna Murthy, MBBS, MS Obstetrics and Gynecology, MRCP Ireland, DFFP, postgraduate certificate, MRCOG, FRCOG, Senior Consultant in Obstetrics and Gynecology, Medway NHS Foundation, Hospital, UK. Dr. Krishna Murthy is a Senior Consultant in Obstetrics and Gynecology at Medway NHS Foundation, Hospital, UK. He qualified from the Faculty of Medicine, University of Colombo, and completed his postgraduate training at the Postgraduate Institute of Medicine, Colombo. He undertook further advanced training in obstetrics and gynecology through the Royal College of Obstetrics and Gynecology, Faculty of Sexual and Reproductive Healthcare, King's College London, and Royal College of Physicians of Ireland. His special interests include the management of high-risk pregnancy, maternal medicine, minimal access surgery, including laparoscopic hysterectomy, gynecological scanning, and medical education. Our third panelist is Dr. Gerald Eru Fernando MD, Medical Director of Addiction Services, Psychiatric Wellness Center Division, Medical Director at Aspire Behavioral Health, Bakersfield, California, USA. Dr. Eru Fernando MD is a board-certified psychiatrist who specializes in addiction psychiatry and is presently the Medical Director of Addiction Services at the Psychiatric Wellness Center and Division Medical Director at Aspire Behavioral Health, Bakersfield, California, USA. After completing medical school, he finished his residency in psychiatry at Harvard South Shore and his addiction psychiatry fellowship at Boston University, Massachusetts, USA. He has experience in political advocacy regarding harm reduction practices and quality improvement projects involving substance use disorders, in particular opiate use disorder. Dr. Fernando has given several COVID-19 presentations related to mental health. He was a resource doctor for Major League Baseball's MLB 2021 rookie program in the USA. Those three are our panelists and our And our coordinator is Dr. Preethi Wijegoonewardene, a senior family physician, chair MCPG board CGPSL and MRCGP International South Asia board, past president CGPSL and SLMA, and the past president of WONCA South Asia. I present.
Thank you, Mr. Chairman. I'm delighted to be the moderator for this very, very important session on COVID vaccines and immunity, and more than delighted to have 3 Sri Lankans who are experts in their own field, selected fields, talking to us on the COVID-19 vaccine, which is a burning problem. And there are new questions coming up every day. We are all learning every day. So it's amazing that how we go on with this problem, which has been all over the world. But so delighted to see Suranjith. I've known you from your school, college days in medical school, absolutely. And nice to see you. Nice to see Krish and Eru. Nice. Very welcome to all of you. And let's start without much ado. Can I request Suranjith to first open up?
Yes, thank you very much. Thank you very much, Dr. Matthew. Thank you very much, the whole council of the College of General Practice of Sri Lanka. It is wonderful to give this talk, and I think we have 2 from the UK and 1 from US. I know Eru is very early in the morning in the US, and what we'll do is 3 of us will talk for 10 minutes each, and then we'll take all the questions. I will just share my slide at the moment. I'll do a slide share so that we can proceed with the process. Just a minute. Okay, can you see my, right. Let's put the presentation mode. Is that okay? Presentation mode. Okay. Yeah. So now, if we go, I mean, so these are the panelists and the moderator and Dr. Matthew. So what I'll initially do is talk about an update on the vaccines, and then we'll do all the questions. It's just an update to get you all back on, to get you all sort of laying the foundation, and Eru and Krishna will do the same thing. So we know that everyone would know SARS-CoV-2 is the virus, COVID is the infection, millions of cases, millions of deaths around the world. And we have been going through this for the past 1.25 years. We have to get the pandemic under control, social distancing, hand washing, wearing masks, lockdowns, etc. have been going on for some time. However, we still find that when we release the brake, the cases increasing. Therefore, vaccinations have come in a big role around the world to try and get this pandemic under control. Now, when you look at the vaccines are against the spike protein. That is the protein on the surface of the virus, right on the surface. You'll see in that figure the spikes that are coming out from the surface, and that is the vaccine has been directed against that aspect of the virus. There are 7 vaccines that have been approved so far in the world. 4 have failed, and that's an important aspect because not every vaccine that they started developing was a success. That's important because people will think, it was developed within 10 months, so therefore everything was successful. No, that is not the case. The process was going parallelly, and that was why they were able to get the vaccines out without taking any shortcuts. But some have failed and 7 have been approved. More than 500,000 vaccines have been given in the world. It's close to 700 million vaccines have been given in the world so far. So it's a big number of vaccines, not tiny thousands, etc. It's a big number. And the important thing from this slide is that once you get the vaccine, you want antibodies, IgG antibodies, IgA antibodies, G for Graham, and you want CD4 cells and CD8 cells. And it takes time. That's a very important aspect to remember. It does not come in one day those immune responses don't come in one day after the vaccination. It takes time. It takes about 5 to 10 days or up to 14 days up to those responses to appear. So that is an important concept to remember. These are the vaccines. I've selected 5 vaccines that is widely used, and there are 2 other or 3 other Chinese vaccines that have to come into the list. And as you can see from this slide, the most vaccines, you have 2 mRNA vaccines, that's the Pfizer and the Moderna vaccine. You have a viral vector vaccine, which you can discuss in the discussion part question. You have 2 viral vector vaccines, actually 3 viral vector vaccines on this slide: AstraZeneca, Gamaleya, and the J&J vaccine. 4 of those vaccines listed here need 2 doses. The J&J vaccine only needs 1 dose. You can see the difference in temperature, very low temperatures for the mRNA vaccines. And you can see the efficacy in the clinical trials, 95% in the mRNA, but lower efficacy in the viral vector vaccines. And the cost, the mRNA vaccines are more costly and more difficult to get to different parts of the world, while the viral vector vaccines are definitely much cheaper than that. And the AstraZeneca vaccine, Oxford AstraZeneca, is the cheapest of the lot. So using these, we have these vaccines. The UK government set out these 9 groups to vaccinate. The older people came first, over age of 80, healthcare workers, social care workers, etc. And now close to 30 million of the population, adult population in the UK have got the vaccine, because still children less than 18 years have not been given the vaccine because it has not been approved for that age group, but trials are going on. So real world data, we want real world. We know that clinical trials are positive, good efficacy was there. Remember, efficacy is when you have clinical trials, effectiveness is when you do real world data. That is the difference of the 2 terms. So if you look at this, the real world data, we have data from the UK, US, Israel, that has vaccinated a good part of their, a good proportion of their population. And all these show that the Pfizer, Moderna, the Oxford AstraZeneca vaccine has very good effectiveness, because it's a real world evaluation. It's in the 80s, 80 to 90%. So that is really, really good. And that is especially effective in reducing deaths and hospitalization. And also it reduces a 4-fold decrease in viral load. So therefore, it may have a role in decreasing transmission, which is very important as a secondary factor. So initially it is effectiveness in the real world to reduce severe infection, hospitalization, death, and then we want to reduce the transmission to bring this pandemic under control. And you can see in the graphs the picture seen in England after vaccination came in. There was a rapid downturn in the number of cases, number of deaths, and number of hospitalizations. Viral variants are an important thing. These are the important variants. The UK variant, the South African, is B1351. Then you have the P1 and P2 variant, which are the Brazilian variant. And again, you can find that the vaccines are effective, but more effective against the UK variant as opposed to South African variant. And that is why we should have, the idea is to vaccinate people around the world as soon as possible, because if you can reduce transmission, the chances of their new variants developing is very much less. If you have millions of people getting the infection, then the chance of it being newer variants coming in is very much higher. So I've told you in that slide, we have written quite a lot, and these have been published in the Sri Lankan papers and journals, etc. You can read it if you want more information. So of the variants, the immunogenicity is reduced, particularly reduced in South African variant, while in the UK variant, it is not so critical. And when we look at the comprehensive preventive measures that have been going on, these are the preventive measures: travel guidance, workplace guidance, etc. But this has a social and individual cost. You know, across the world, people are complaining that it's having a massive economic cost, individual cost, societal cost, etc. And that is why vaccines come as an important pillar in bringing this pandemic under control. We have a state called fully vaccinated individuals. That is, if you have had the Pfizer, Moderna, or the AstraZeneca vaccine 2 weeks after the second dose, or the J&J vaccine 2 weeks after the first dose. Why is this important? Because of the quarantine implications and vaccine mandates. Certain people are not allowed to travel or go to different places if they are not received. They have not got this appropriate vaccination and with a negative PCR. So that is another important aspect to remember, the fully vaccinated, which has important implications with regards to quarantine. So this is a quick run through just to build up the foundation for us to answer the questions as we go on to the next segment. And I will hand it over now to Dr. Krishna Murthy, COVID vaccination in pregnancy and fertility. Thank you.
Yeah. Good afternoon. Thank you for inviting us. So we will just explain COVID vaccination in pregnancy and its effect on fertility in a short presentation. Next slides, please. Yeah, so this is the article we wrote with Professor Seneviratne about a couple of months ago in the Sri Lankan newspaper, just explaining the pregnancy and breastfeeding during COVID outbreak. So it's quite informative for general public's advice. You can also use it. So today we are going to discuss these areas so briefly. So if you got any questions, we will discuss all of them. So that includes what is COVID in pregnancy means, what's the current advice on pregnancy and COVID vaccination, and the mode of delivery with COVID infection, breastfeeding, and COVID vaccination, as well as COVID and fertility. Next, please. Suranjith, next slides.
Yeah, it is on.
Yeah, oh, sorry. Yeah, so COVID in pregnancy. So most of the women, they present with asymptomatic status or with the mild to moderate symptoms. So the current advice is to keep up with the social distance, hand sanitation, and wearing face masks during pregnancy. So also we advise them to avoid being in contact with anyone suggestive of COVID infection. The risks are mainly in the third trimester, that is after 28 weeks of gestation. That's a risk of severe illness. So currently it's noticed that there's a risk of prematurity, slight increase, but there is no risk to the baby's loss while being inside the uterus. So next slide shows what is the current advice on COVID vaccination during pregnancy. So in UK, so we advise vaccination for the people who get highest viral load exposure, as well as clinically extremely vulnerable. So the people, extremely vulnerable group, healthcare workers and social care workers are offered COVID-19 vaccination. So there are more studies going on as each and every pregnant lady having the vaccine, they will be entered into a data, so they are being followed up as well. So we will have more information in future. So when it comes to end of the pregnancy, there can be an issue with delivering the baby. So currently how we advise is for the patients to go to the hospital when they're in labor. So our advice is to stay at home until they start the labor. The reason is to avoid exposure, also to reduce the spread. So if we have a patient, someone with asymptomatic but with positive PCR for COVID, the recommendation is to deliver at the hospital. The staff wears the PPE, and we keep monitoring the baby and the mother, expecting a normal birth. So at the time of delivery, we get the neonatal team involved. Then if someone presents with symptoms or suspected without a PCR, suspected COVID infection, who goes into the hospital in labor, we involve multidisciplinary team. So that includes obstetrician and gynecology doctor, anesthetist, physician, maybe respiratory physician, as well as their midwives. In UK, we have specialist midwives, as well as the virologist. Depending on the situation, they might need different treatment options, so that's the reason. So here again, to stress that these patients are allowed to deliver for the obstetric reason. So we don't need to do anything differently, but we have to keep them monitoring. And if we have somebody who is in labor who had COVID infection in the past, there's a small risk of having a smaller babies inside the uterus. So in those situations, we have to consider doing ultrasound scan and assess the fetal growth. And depending on their clinical symptoms, we have to offer them the personalized care. So that means you just individual care is arranged. So current advice on breastfeeding and COVID vaccination is for the eligible mothers, we offer the COVID vaccination. Even if they're breastfeeding, you can continue to have the vaccine and continue to breastfeed. So in UK, the groups that are offered the vaccine are the clinically extremely vulnerable group. So where the disease can be life-threatening, as well as the frontline healthcare workers and social care workers, where they get exposure to more viruses. Again, as I said before, there is more studies going on, so more data will come in future, so we can update you. Then COVID and fertility. So currently, lots of institutions in UK, US, Europe, and rest of the world have looked into them in detail. There is no data to show the vaccine is safe. The data shows vaccine is safe. Vaccine does not affect fertility at all. So if someone is trying for a pregnancy in few years' time, or currently trying for a pregnancy, or going through the fertility treatment, including IVF or other forms of treatment, they can continue to receive them. And in UK, the British Fertility Society is the group which controls and advise on fertility. So they have advised this can be continued. And there was a recent guideline in February 2021. Next, please. So in summary, so if you can take these messages for your patients, so that will be very helpful. So in pregnancy, when they're extremely vulnerable, COVID vaccination is given. So mode of delivery depends on the obstetric indication. And during labor, we monitor the mother and the baby. So during breastfeeding, among the eligible mothers, currently we offer the COVID vaccination. And COVID vaccination does not affect fertility. Yeah, that's it. Thank you.
Can we move on to Dr. Eru?
Yes. Hi, everyone. Thank you so much for having me. I'm Dr. Eru Fernando, and I wanted to talk mostly about mental health and just how much it plays a role in COVID-19. I don't think we really think that much about it, but my hope is that we can really talk more about it today. And so the first thing I really want to talk about is how the beliefs and myths about vaccines really can play a part in people not getting the vaccine, and how much we really need to go and try to dispel these kind of rumors. And what happens if a person does not get the vaccine? They may not realize society hasn't really talked that much about how mental health can be really affected both directly, indirectly, and also with the syndrome known as long COVID. So we'll be talking about that in a little bit. So talking about the different beliefs and myths about vaccines. So again, we have to remember that this is all mental. The more that we can convince someone mentally that it is okay to get a vaccine, the more that we can defend our society and our community. So the first thing that we should really talk about is the double-edged sword of the internet. Now, the reason I say the double-edged sword is I think firstly, that the internet is amazing. I would not be able to speak with you today so easily all the way from United States and California if it wasn't for the internet. Even within the last 10 years, we all know how much it has really improved. But the downside of it is because of the rapid transmission of information, the disinformation occurs in a much more rapid state as well. So unfortunately, we have to understand that human beings are afraid of the unknown. COVID-19 is completely new. No one knew anything about it. We've all had to adapt in real time. And so a lot of the things that's been happening is people just posting things on the internet, all these different myths about vaccines. So they may say that, you know what, it's happened so quickly. How could we know it's so safe? Or they could say that vaccines itself can give you COVID-19. Some people say that it leads to long-term effects. Some people say it can alter your DNA. Some people says it can make you infertile, and then others say that you shouldn't be taking it if you're pregnant or breastfeeding. Again, there is no data to support any of these claims. And so it may be very common for your patients coming to you and asking you these questions. And I think it's important for us to be patient, to understand that we live in a world of disinformation, and try our best to just be calm when we're telling them that the research does not show this, and there's a lot of data to show that it's very safe. If you look at the next graph over here, we can see the amount of people who were definitely not planning to get the vaccine, and this is the United States. And every month, as you can see, going from December, January to February, more and more people are getting the vaccine, more and more people are open to receiving the vaccine. So the more that it becomes normalized, the more that we see everyone else getting it, the better, hopefully, that these statistics will come. One tip I really wanted to give you, this is from Dr. Matish Patel over at Penn Medicine, is that he found that if you said that the vaccine is available to you, as opposed if you actually said, we have reserved a vaccine for you, we saw an increase of 11% more people likely to get that vaccine. So even the verbiage, even the vocabulary we use for our patients could be extremely important. We have to market that this vaccine is something that they should be getting and that we reserved it for them. Next slide, please. Next slide, please. So the one thing that we also have to remember is that COVID-19 actually has a lot of effects on mental health. Again, something not talked about. So directly, people can have cerebral vascular events, meaning that 74% of those individuals had a stroke, 12% of those individuals had an intracerebral hemorrhage, 51% of those individuals were 60 years and older. So that happened more usually with people, or that was about 82% of those people were 60 years and over. So that was usually more in the older populations. Whereas about 50% of those people had altered mental status, meaning that they could have just had a simple type of inflammation of the brain. However, they could have had a psychiatric diagnosis as well. So they could have had psychosis, about 43% of those individuals had that. Some people can have a dementia-like syndrome, about 26% of those individuals had that. And then 17 had things like affective disorders such as depression or anxiety. Next slide, please. And of course, we have to remember what happens when we cannot get the infection under control. What happens? We have lockdowns. And the lockdowns, and what I would like to say, the indirect effect of COVID-19 on mental health has been devastating for our society. So even all the way in June 2020, just a couple of months later in the United States, we saw that people had much higher incidences of suicidal ideation, thoughts of suicide, using more substances, whether it be alcohol or drugs. We saw that anxiety disorders were 3 times more that of the year before. Depression was 4 times more likely. 1 in 10 people had started to use more alcohol or drugs during this time, and people were more suicidal, about twice as much compared to 2018. Next slide, please. Another thing that's rarely talked about was that there was a huge amount of teen or adolescent suicides. In fact, the 5th largest school district in the United States, in Nevada, decided to go back to in-person student teaching only because 18 children had died from suicide during the lockdown. And they had found with their alert system that more than 3,000 potential suicide risks were happening. So without a doubt, and I've seen this in my own practice, kids, everybody is much more down and depressed because of the lockdowns. Unfortunately, domestic violence has also risen among the lockdown, mostly because of females getting abused. And unfortunately, child sex abuse has drastically increased. In fact, there was 22% more calls at the end of March, and about 80% of those individuals were living with that individual who had been harming them. Next slide, please. And something that is now coming more and more known to us, again, we need a lot more research, but what is known as long COVID, also known as chronic COVID syndrome. So this means that, weeks or months after the usual illness period of time, people could still have fatigue, shortness of breath, what people call brain fog, so just feeling very cloudy in your mind and your processes. You might have issues with your sleep. You might have fevers. You might have issues with your stomach. You might have anxiety and depression. This can last for months, and sometimes some people even say for years. And so some people say it's mild, but some people say it's completely debilitating. And the last piece of information I posted here was showing there was a very famous restaurant chain in the United States called the Texas Roadhouse. This individual, the CEO, was worth 600 million US dollars, and he died by suicide because of unbearable COVID symptoms. And that what he experienced was tinnitus, the extreme ringing of the ears. Another thing that can definitely cause people to have more depression and suicide. So I say this because it does not matter how much money you have, how much support you have. At the end of the day, getting COVID could definitely cause you to not only have depression and anxiety, but cause you to want to die by suicide. So it's extremely important to be able to get our patients to get the vaccine, because if they were to get COVID, the results could be disastrous. So hopefully this will be enough information for all of you to encourage your patients to get your vaccines. But with that, I really want to thank everyone for the presentation. We'd be happy to take any questions that you have. Thank you.
Thank you, the three of you, Suranjith, Krish, and Eru, for that wonderful presentations. Very brief and nicely summed up in a few points. And I think you answered most of the questions that we GPs have amongst ourselves, but now it's open for questions, and we'd like to see how many questions have come in. Shobavi? Oh yes, there's one question, anonymous person. What are the guidelines for giving COVID vaccine to patients on warfarin and on chemotherapy? Suranjith? Did you get me?
Oh, sorry. Sorry. Yeah. Can I take the warfarin part of it? Very good question. So basically, you'll have to get your INR, because you'll have to have monitoring and get your INR into an acceptable range. And then you have to, there are guidelines laid down by the Sri Lanka College of Hematologists and internationally, stop the medication for the appropriate amount of time to be able to get the vaccine, and then start it after that. It's a very direct process, very easy to follow process, and the international guidelines are there. You can just refer that and do it, but you have to get the INR into the correct range. Immunosuppressed patients, yes, the vaccine is safe to be given in immunosuppressed or immunocompromised patients, but what we don't know is what response there would be with that vaccine. So sometimes we may have to give them a booster, but we have to remember that it is not only antibodies that we are looking at, because a number of people have sent me antibody reports to say whether they are protected. We do not have a immune correlate of protection at the moment. You cannot just look at an antibody report and say, okay, you're protected, because we are waiting for that immune correlate. And the important thing to remember is it's not only antibodies, it's T cells. T cells are important, CD4 and CD8 cells. So immune deficient patients, you would give the primary immune deficiency or secondary immune deficiency, or people receiving immunosuppressive medications for cancer or autoimmune disease, you would give the vaccine. The important thing is to follow certain guidelines. If the person is receiving rituximab, then you wait for some time after. Rituximab is a medicine that affects the B cell. So you wait about 2 months after after rituximab to give the vaccine. But that group of patients were targeted in the UK. I know there was some information going around where the number of people approached me because they had been told that if you're having cancer, you should not get the vaccine. That is absolutely wrong. You should get the vaccine, because that was a target group. I put the target group in the slides which I presented in the UK. That was a target group, because if that group of patients get COVID, the severity is so high and the chance of death is so high in that population. So there are very well defined guidelines for people on aspirin, warfarin, clopidogrel, etc. The Sri Lankan Hematology Society has also put out guidance on that. And when it comes to cancer patients, please give your patients the appropriate treatment, time it with the cycles, etc., which any oncologist will be able to advise you on. Thanks.
Yes, there's one more question coming in. Is it all right to have the second dose from another vaccine brand?
Shall I take that?
Yes, please.
Yes. Okay. Yes. So I think now the world has a shortage of vaccines. You know the big problems that there are. The UK fighting against the arguing with Europe, etc. We don't have vaccines, right? I mean, certain countries had vaccines, but a lot of countries do not have vaccines, and there's vaccine shortage. And now people are thinking of giving a third booster in the post-summer or at the end of summer. So we don't have vaccines, and trials are going on at the moment to give the Oxford AstraZeneca vaccine followed by the Pfizer vaccine, or Oxford AstraZeneca vaccine followed by the Gamaleya, the Sputnik 5 vaccine, followed by the sort of other vaccines. So those trial data will come out. If you spoke to me about 3 months ago or 2 months ago, I would have said the present data was, if you receive the first vaccine from one manufacturer, you should receive the second dose from that manufacturer. However, things are moving now, and it will come to a situation around the world with the vaccine shortage that are there and the massive shortage that people are facing around the world, not only in 1 or 2 countries. We have to remember, we have to vaccinate billions of people, and many of the vaccines need 2 doses. So we may come to a situation where we may have to use a different vaccine as a second dose, but the clinical trial data will come out soon, and it's in that group and in children, and those are what we're waiting for. And as soon as the trial data comes out, everybody will be highlighting that and advising people.
Thank you, Suranjith. Can we, one more question to you. I think that how long after a blood transfusion can a vaccine be given? Again to you, Suranjith. After that, we'll move on.
Oh, okay. So I mean, a lot depends on the indications for what we are giving the blood transfusions, etc. There are several factors that you would take into account, because when you get a blood transfusion, you're getting for some reason. So the important thing is, once you give the vaccine, you want an immune response to occur, and that takes about between 5 days to 14 days. I mean, you want the immune response. So the immune response would occur. The protein is produced, and the immune system will attack the spike protein and produce the antibodies and T cells. So therefore, depending on the condition for which you are given the blood transfusion, that means if you wouldn't want to give the person in sort of critical care, very ill at that moment, the vaccine at that particular time, you just want to delay it a little bit and then give it when the person becomes better. So I would say about a week after that, or depend on the clinical scenario, you should go and get the vaccine if you are in the correct appropriate group. That is the one that has to be followed. There has to be a process in which the vaccine is given, and I know in the UK that was followed wonderfully, where there was a process in giving vaccines. I was a doctor. I could not just go and get my children vaccinated because of the aspect that because I was a medic, there was a routine to be followed. And with that, the sort of deaths, hospitalization, etc. were reduced, because that is the main group that was were dying, going to hospital, which was targeted. So you depends on the clinical scenario with the blood transfusion, but you would give it say in a standard situation after about a week or so you can get the vaccine.
Thank you. This is one question from the audience here. Use the mic, please.
So
yeah.
I'm Dr. Sabeshan. So thank you very much for all the three speakers, and congratulations, very beautifully done. My question is going to be this: AstraZeneca has been criticized for intravascular coagulations. And in Europe, AstraZeneca vaccine has been criticized, saying that it causes intravascular coagulations. So here in our country, people who had ischemic heart disease already got it. So this criticism, is it a true, or are we in danger, or we are safe? What the situation is, Prof?
Very good question. I don't know if you read that, because about a week ago, we wrote I'll send you that link, and that specific article with all the data around the world about coagulation and Oxford AstraZeneca vaccine. Yeah. And major bodies have looked at it, have gone through all the data. Close to 20 million people in Europe and in UK have received the vaccine. And it does not increase the risk of coagulation, increase the risk of clots, blood clot. We wrote an article, and please share that link, because that has been all described in detail. The European agency, the British agency, the WHO, the company, the different experts in the area have all come out. There is a very, very, very small number, tiny number of people who developed some cerebral vein thrombosis, but that was a effect, extremely low number of patients, but generally blood clots, it does not increase. And that was the reason we wrote that article, because to highlight that fact, and that was published in one of the local newspapers, and that link can come. All the evidence data that was cited is given in that.
Oh, thank you.
Thank you.
Thank you.
Yeah. Okay, Dr. Sabeshan, are you satisfied? Yeah, that in fact came in the newspapers also, that article, and I think that reassured us as GPs to reassure our patients on that, because this is a common question asked.
Because that was a common question asked, and that was the reason for putting something on paper, so that all the evidence can be evaluated. Absolutely.
Yeah. Can I throw one question to Dr. Krish? There's a question. They asked, what is the recommended trimester to get the vaccine, Dr. Krish?
Yeah. So currently we advise after 12 weeks of gestation. The reason is being after 12 weeks, all the organs are formed, so they can have vaccination after 12 weeks. So it's at the moment, the advice is for the eligible groups. So it's expanding, because a few days ago, there were more patients added onto the list, including body mass index of over 40, as well as with gestational diabetes. The other question that comes for the vaccine is, when would you give a second dose if someone becomes positive with the pregnancy after the first dose? Again, the advice is, once you receive the first dose, you continue with the pregnancy, and they can have the second dose after 12 weeks of gestation or 12 weeks from the first dosage, whichever the one latest.
Yeah, thank you.
Thank you.
Following on that, there's another question. Is contraception necessary after a vaccination? And if so, for how long? I think
currently, if someone is using the contraception, they can continue to use it if they want to use it for the contraceptive purposes. If someone is having the vaccination during the reproductive age, they don't need to have a pregnancy test, first of all. And they don't need to use contraception either, because the similar vaccines like tetanus vaccine and as well as influenza vaccines are given during pregnancy, and they have long-term safety data. So they don't need to have a contraception because of the vaccination.
Okay.
That's the advice.
Thank you.
Thank you.
That answers that question. Dr. Hettige from the audience, please. Yes.
Yeah, my question is now most of these vaccine, the antibodies are developed again only spike proteins. But the Sinopharm vaccine is as I heard, it's an inactivated vaccine. So does it is it a better option for these variants, the Sinopharm vaccine, because it's the whole inactivated vaccine which is being injected?
I think Suranjith,
okay, that is a very good question. A very good question that is asked, and that is why different formats are coming. So if the question is, if we can use an inactivated vaccine, we are using a lot of protein, so therefore better widespread immune response could be coming in. That has been again, please read that article which was written on the Sinopharm vaccines, on the different, there are two types of Sinopharm vaccine manufactured by the Beijing and the Wuhan consortium. And the way the vaccine has been designed is most of the immune responses have been against the spike protein, even in that vaccine. So but the newer generation vaccines, like there is a vaccine developed in California that they are trialing in South Africa at the moment. That one you're using particular adjuvants, which you would like, you do need to use an adjuvant. Adjuvant is something that helps the immune response. When you're using an inactivated vaccine, inactivated means a killed organism. You want to use an adjuvant to help the immune response. And in the Sinopharm, it is predominantly a spike protein response that they get, but there are newer adjuvants that people are using that will be helpful to be able to produce response against the nucleoprotein, against membrane, and the other non-structural proteins which you would like to have a more broader response. Vaccines are developing. We are very lucky to get a vaccine, such good vaccines in this time period. In June 2020, if you spoke to any immunologist around the world, they would have been very skeptical about the possibility, because HIV, TB, malaria, dengue, we don't have good vaccines. And we have been trying to get vaccines for years on it. HIV is a different virus, it mutates a lot very frequently, etc. Influenza, the vaccine effective is 60%, but still we use it, changing vaccines every year. So we were taking a big gamble with this vaccine to see whether we can develop it. And when the responses came, efficacy came at 95%, right, 70%, 90%, those were wonderful responses, but we have to improve the vaccines as it goes further. That is, we have to develop vaccines against the variants. We have to develop vaccines in a better administered form, nasal vaccine, so that the immune response occurs nasally. So to answer the question, it is, yes, the killed vaccines, you're using the whole organism, you're using an adjuvant, you have to use an adjuvant. And that is an important aspect to remember with regards to the adjuvant. Alum is one of the adjuvants, and there are other adjuvants that are used. You want to get the immune response, but when the Sinopharm vaccines, in that article, if you read, we have specifically, in that article that was written, specifically told the immune response with the Sinopharm vaccine, it is mainly against spike protein like the other vaccines.
Just not one more question.
Okay, quick one.
Now we know there is B and T lymphocyte activity. Now the antibodies which is produced against this virus, does it act on at the level of the alveoli? Is these antibodies present in the respiratory secretion, cellular secretion to deactivate the vaccine before it get attached to receptors, or is it after it get attached? How does the antibodies actually works? Has it been looked at?
Yes, so I think those again, now when it comes to doing studies, it's very much easy to get a blood sample. We know that it's very much easy to get a blood sample. If you have to get a skin swab, it's easy. Blood sample is a small event of intervention, but it's very much more difficult to study the lung. Those studies are going on now. Bronchial lavage, etc., is not the easiest thing to do. So when we look at blood sample, most of the studies at the moment are on blood. Most of the big studies on blood samples. You look at antibodies, you look at T cells, you look at CD4 cells, you look at CD8 cells, you look at the active processors, then you look at memory, you need immune memory, and that is immune memory is the one that resides in the body, so that in the future, if you get infected with that same virus or bacteria, the immune system kicks into place very much faster. So you have immune memory, you have the plasma cells that are lasting, that if you are infected, the plasma cells and B cells, if you're infected with the virus, those will become activated very soon. So now the question you asked is, what about the lung? Yes, so studies are being done in the lung, and the hope is that there will be antibodies going not only in the blood, but it will go into the lung. The cells will go, CD4, CD8 cells will go into the lung. But we are waiting for that actual data. It's very much difficult to do that, because, sometimes if you are doing to look at CD4 cells, you can look at bronchial lavage. Sputum is one, but that is at the top, at the upper airway. You will want to look at bronchial lavage or biopsies, and those are more interventional. You have to do specific procedure. So we are getting a lot of data from the blood, and now the next set of studies will come where we are expecting, as soon as the virus comes, it will get into the epithelial cells, it will start multiplying, it will multiply exponentially, and that process would be immediately brought down by the antibodies in the local environment, plus cells in the local environment, but we are waiting for the really formal studies to demonstrate it. The indirect ways, does it prevent infection? Does it reduce infection? And that we are getting already from real world data. We are getting that infection from the world, from the countries that this vaccination has been given to. So that is what we are saying, what people are saying. Yes, it is having the effect in the blood, and in addition, it is having effect probably in the airway, etc., because that is how the whole process is turned, and the infection risk plus the infection risk is transmission risk is reduced by about 60%, and the death, severe disease, etc., is reduced a lot, majorly reduced with the vaccines. Okay, very good question.
Thank you, sir.
Thank you. That was very clear, Suranjith. I quickly like to throw a question to Dr. Eru, because there have been series of questions to him, but we'll make it give it in a nutshell. How to overcome different cultural, religious stigma attached to the COVID vaccine, and how to overcome vaccine phobia. Now, this is a bit of a broad thing, but if you can sort of briefly tell us, because this is a common thing in our Asian countries, these phobias and all kinds of different cultural, religious beliefs, etc., and stigmas. So, can you just enlighten us a bit on that?
Absolutely, yeah, and I have to say, it's not even just an Asian phenomenon. That these are the same issues that we're having in the United States as well. The very same, disinformation that's going around. It's difficult. It's difficult because at the end of the day, the best shot you have is to use that kind of trust that hopefully your patient has with you. And so the only thing you can say is, hey, listen, I got the vaccine. What questions do you have? What fears do you have about getting the vaccine? The best you can try to do is educate them. But it is going to be difficult. Some people have already made up their mind to believe that they're not going to take the vaccine. And so that is difficult. But some people are going to be on the fence. Those are the individuals that I think that the more that you talk with them, just keep it a very human conversation between two individuals. that's the best way that you can try to convince them that the vaccine is not going to only protect them and their loved ones, but again, maybe they, like even telling them that there's a lot more other issues with getting COVID, for example, all those mental health issues. I don't think a lot of people know those kind of things. So perhaps even saying all the different things that can happen and saying and trying to show them that the vaccine is okay. That's the best option that we have at this point.
Thank you, Eru.
Could I come in with one small point there, Dr. Preethi? Can I just bring in one point?
Go ahead. Go ahead, please.
Hello. No, just to tell you that there are two states. Just adding to Eru, there are two states. There's vaccine hesitancy and anti-vaxxers. So vaccine hesitancy is the people we generally meet, right, who are asking. That's very important. It encourage them to ask questions, we answer them. There are the anti-vaxxers who can be, what happens is you can never convince them. Their belief is that if they believe that Sri Lanka is a country in Africa, they will believe it. You can talk to them till your face goes red or blue or any color, they will never believe it. And there are a few people who have received the vaccine who are still anti-vaxxers, right? They have received the vaccine, they are doing a big disservice to humanity. So the important thing is focus on the vaccine hesitant people, because they want to know, advise them, teach them, and then they will realize what the position is. That's a quick update I just wanted to give you.
Thank you. Yes, we have a question from the audience here, Dr. Chandrasekhar.
My question is, is there any limitation as to vaccinating people, let's say in late 90s, maybe 97, 98, especially if they have allergic history or bronchial asthma like thing, but under control? Is it safe, or what are the pros and cons?
So the answer I gave, I'll take that question. Answer I gave to a lot of people who asked the same question is, in the UK and US, we see a lot of people over the age of 90, 80, they come to clinic and we see a lot of patients. And the Queen, who is 95, received the vaccine very early. Prince Philip was 99, he received the vaccine. So a lot of people over the age of 90 have received the vaccine, because if you get COVID at that age, the chances of dying are so high, are very, very high. And you wouldn't give a product that is dangerous to the Queen of England, and she was over 90. And the important thing to remember is that allergies, the Pfizer vaccine, there were some people who had very severe allergies who developed allergies initially, but now it's about 4 per million, as opposed to any vaccine giving an allergy risk of 1 per million. So it's about 4 times the rate. The AstraZeneca vaccine, people don't talk about allergies. That's generally, we don't really talk too much about allergy, because it's not an allergic readout. Any vaccine can produce an allergy, any medicine can produce an allergy, but that is background risk. So the idea about 90-year-old is that, around the world, people over 90 have a very high risk. So therefore, they are targeted to get the vaccine. That is a group they target. Some people say the person at 90 doesn't go out of the house. They don't do anything. They are not mixing with people. So therefore, why should we give the vaccine, etc. But the problem is, there are relatives of our population. We love to be with our relatives. We visit them. We go and meet them, etc. And therefore, younger people are going to see them. Carers are going in and out of the house, etc. So we have to take that into account, and those people can be taking the virus to the person who is very much at risk of getting. So what about giving them some immunity rather than them having no immunity at all?
Thank you.
Right, thank you. That makes it very clear. Dr. Eru, were you trying to say something again? The co-chair says you have been trying to add on something. Is there anything you like to say, Eru?
Me?
Yep.
No, nothing. Nothing else to add.
There is one question to you actually. With the post-vaccination, any psychological impact to worry about for GPs?
For the GPs itself? No. No, I have not.
No, in dealing with our patients who have,
Or patients, yeah. No evidence, no data to show that. Even anecdotal, I haven't heard of anything like that happening either. All the issues would come from COVID itself.
Thank you.
In terms of long-term mental health
There's
issues.
one more question online. What is the time for giving COVID vaccine for a COVID positive patient? I think that should go to Suranjith, I presume.
Okay, yes, it's so what we follow now is now very interesting, wonderful question. Data is coming every other day. Data is changing, right?
Yep.
So, and we are following it very carefully and updated. So in a nutshell, we wait for about 1 month after having COVID, because, recover from the COVID. You don't want to go to hospital to get vaccines or to other places and spread COVID while you're having COVID. So wait about 1 month. This might change a bit. It might go a bit longer to 3 months, but at the present moment, we wait 1 month. Should people who have had COVID in the past get vaccine? Yes, definitely they should get vaccine. At the moment, they should get 2 vaccines. That again might change. Data is coming. 4 studies have been published. We are saying that the immune response after a single dose of a vaccine in person who has had COVID is the antibody response at least, and some of the T-cell response are really great. So therefore, we might come to a situation where a person who has had COVID in the past get only 1 vaccine, at least 1 month after they have the COVID. But at the moment, the present guidelines, if I'm telling you the present guidelines, is to receive two vaccines in 12 weeks apart, and the first dose to be given 1 month after the person has COVID.
Yeah. Yes, one more question.
So I am Dr. Namal. My question for Professor Suranjith, regarding the post-COVID patients. For the post-COVID patients, how long immunity will persist? Can you elaborate about the immunity of the post-COVID patients? The persistency of the immunity.
Very good question. Again, that's a talk on its own, and for the immunology, for the Sri Lanka Allergy and Immunology Association on Friday, I gave this talk on COVID, immune responses after COVID, what's known so far. So in a nutshell, if I put that, so you have antibodies you expect after COVID, you have the innate immune system, and the innate immune system in the people who are getting severe COVID doesn't seem to be working too well, and it's delayed, right? So that is the group of certain amount of people who are getting severe COVID, that is innate immune system, first part of the immune system. Then you have the second part of the immune system called adaptive immune system, which is antibodies and T cells. T cells can be CD4 T cells, CD8 T cells, and then you have the B cells. So that's called cellular immunity. So if you look at antibodies form very early, IgG, IgM, and the initial studies said that they last only for about a few months, 4 months, but now the new studies, they have gone up to 6 months, 8 months now. They have done some studies from San Diego, and they said the antibodies tend to plateau off about 6 months, but you still have antibody, but it seems to be going down a little bit. When it comes, and that is why people wonder whether we should give them another second dose of vaccine like the influenza vaccine, not second dose, a booster like the influenza vaccine. Then when it comes to the CD4, CD8 cells, the study that was published recently from the San Diego group clearly showed that both CD4, CD8, it's a range of proteins in the virus, and it is persisting up to 6 to 8 months. So the immune response is persisting, and what we want there is memory response. We have the acute response, the immune system should get activated, and then after that it should come to baseline. You don't want to get it to be activated too much unnecessarily. That's how the immune system is activated too much. You get malignance excess, so you don't want that. It has to come down to baseline, but we want memory response, and those memory responses, beautiful studies have shown it is persisting to 6 to 8 months at the moment. So in a nutshell, antibodies, GM, can be waning down. Memory responses, CD4, CD8, B cells, those are persistent. So 5 components are important. They are persisting after SARS-CoV-2 infection. And that is why very few people are getting reinfected. So what are we trying to do with vaccines? Rather than getting people to get SARS-CoV-2 and get all the problems, including the possibility of death with SARS-CoV-2, we are giving vaccines to be able to get those positive responses rather than some of the people getting SARS-CoV-2 and dying from it. And that is the idea of vaccination, to be able to go early.
Thank you.
Okay, thank you, sir.
Thank you very much. There's one more question. I think it's for, yes, for Eru. You mentioned about chronic COVID syndrome and long COVID. So there's a question from, I don't know from which country, from Nepal, GP. Are there any guidelines to manage the chronic COVID disease?
I'm not sure if there's any other presenters that could talk about that. My understanding is it's probably more symptom-based, depending on what they are actually complaining of. But my understanding is that there isn't any particular guidelines yet. It's something that we're still studying at this time.
All right, thank you.
If I can add from the UK,
yeah.
So this is a big elephant in the room that is coming up to immunologists, GPs, rheumatologists, infectious disease doctors. We are seeing a lot of patients with long COVID now, and a lot of money has gone in. A lot of money has gone in from the government to do research on this group. Very, very basic sort of guidelines have been put in. Guidelines means not formal guidelines, but this is how the clinic should be run, etc. From the UK, but as Eru said, we are waiting for international guidelines to come in, because that's important in the US, in Europe, in UK, where lots of cases were present with COVID, big numbers. Long COVID has become an immunologist, the immune system, they have a whole range of symptoms, as Eru explained. So that is what is the big elephant in the room at the moment. And vaccination would really help that process, because otherwise you will have a lot of sick population who get COVID and then proceed to develop long COVID.
Thank you. I think that gives a lot of thought for young GPs who are just coming into starting research to, it's an interesting thing to start on. I mean, in a small country like ours, how we faced it and how we handle long COVID. Another important question is there, of course, this is slightly out of the vaccine. A lot of research on vaccines have been done. Any hope for the treatment of COVID? Other than what we're having now, I mean.
Yeah, so let me answer that. Lots of research has gone into the treatment. So always in any disease, you want to treat it and then you want to prevent it. It goes hand in hand. That's what you do. So treatment, yes, a lot of research. There are many drugs have been repurposed. Many drugs that were used for HIV, for other conditions, have been repurposed for use in patients with COVID. However, treatment has been generally not very successful overall. And that again pushes to vaccinate, because we don't have one blockbuster agent. We use a number of agents in treating patients. You use a drug called remdesivir. You use a drug called, you use dexamethasone, cheap, it is effective. Previous studies showed it may not be. Then the recovery study from the UK showed that it's effective, and we use it in certain groups of patients. There are guidelines in who to use remdesivir, who to use dexamethasone. Then we use a drug because the cytokine storm occurs. The innate immune system gets delayed and then it overacts. So cytokine storm, IL-6, etc. are produced. A lot of cytokines, chemicals that the immune systems use to talk to each other. So can we neutralize? There's a drug called tocilizumab, which is available in Sri Lanka. Again, that is given to a number of patients in the correct context, and there are guidelines that we follow. Then the other one is monoclonal antibodies. Vaccines are presumed to produce polyclonal antibody, and that is, it is active immunity. You want the person's immune system to get the antibodies and the cell. You have passive immunity. Can we give a monoclonal antibody that is being collected from people who have recovered? Those are polyclonal. Can we get a monoclonal made in purified in the lab can give monoclonal antibodies. Again, monoclonal antibodies are used a lot in the States and in the UK. Give it early in people where we don't have much time. They will develop very severe disease. When they, just before getting to hospital, can we use the monoclonal antibody? And finally, the important thing is the use of convalescent plasma that is polyclonal. However, there are mixed data on that. And what they say is if you can get good polyclonal antibodies which are high titer, that may be beneficial in patients with SARS-CoV-2. So it's not that we don't have treatment. We have not investigated treatment option for SARS-CoV-2, but it has been really disappointing when it comes to treatment options. So that is another reason. We have social distancing, we have wearing masks, hand washing, which should definitely occur. We have the treatment option, which are not the real best option, not really blockbuster. So therefore, can we prevent it? And that's the important. If we can prevent it, we won't need to use treatments that are not so great in this population. That is where vaccination comes into play, again, pointing to the importance of vaccination.
Thank you. I'm sad to say we are running short of time. We have lots more questions, I believe, but due to lack of time, we have to cut short now. From all this, I can summarize and say we take it one day at a time, and we are living in hope always. And we fall in line with whatever the recommendations about keeping your distance and washing hands and all that. Still, the bottom line stays the same. And for us family doctors, we have a big role to play, I think, in this whole game. And we are doing our best, but thank you for your wonderful guidance. All three of you, Suranjith, Krish, and Eru, we are so proud of you as Sri Lankans that you are doing so much in other countries, and that we are proud that Sri Lanka has produced such brilliant people in this world. So thank you very much once again.
Thank you.
Thank you. Thanks.
And we look forward to continuing more sessions like this in the future from the College of GPs and all of you. And thank you very much.
Thank you. Thank you very much. Thanks. Bye. Bye.
But how can we forget our very own Dr. Preethi Wijegoonewardene, who moderated the session? I would like to invite our president, Dr. Matthew, to award a token of appreciation to you, sir.
What about the token of appreciation for them? He's going to post it.
Thank you so much.
We have to avoid our co-chair, Dr. Shankar, on the behalf of the college. Thank you very much for co-chairing and with us. And to Dr. Gerald Matthew, our president.